Alterations in immunity and hematology, disorders of the hematopoietic system. Anemia is defined as a deficiency of erythrocytes or hemoglobin. It can be caused by blood loss, an inadequate erythrocyte production, or destruction of formed red blood cells. These clients with an inadequate red blood cell volume are going to experience orthostatic hypotension, a thready pulse, oliguria, or a heart murmur. If they have lost red blood cell function, the body is going to automatically compensate. So compensatory mechanisms are going to be a fast heart rate, so tachycardia, tachypnea. The skin will be cool and clammy, and if women are menstruating, we may see amenorrhea. With the decreased red blood cell function, these clients are going to have dyspnea, chest discomfort, acidosis, headache, vertigo, and pallor. The different types of anemia that we'll discuss in this course are hypovolemic, iron deficiency, pernicious, folic acid deficiency, sickle cell anemia, and hemolytic anemia. With hypovolemic anemia, this is caused by a sudden loss of a large volume of blood or a chronic loss of small amounts of blood. These clients will experience extreme pallor, tachycardia, hypotension, reduced urine output, an altered level of consciousness, fatigue, chills, and a rapid respiratory rate. Remember, hemoglobin transports oxygen to the body, and if we don't have that hemoglobin, that can result in poor perfusion symptoms, which include dyspnea. We can diagnose hypovolemic anemia through a CBC or some imaging, or we can actually visualize areas to help determine the source of the bleed. We can treat this with blood transfusions. It's important to treat the underlying condition or the condition of chronic blood loss. So hopefully we're not doing this repetitively. We can also administer oral IV, or intramuscular iron to help restore hemoglobin. And of course, remember, to stop bleeding, we want to apply direct pressure. With iron deficiency anemia, this means we have insufficient iron to produce hemoglobin when the heme cannot be recycled because of blood loss. Iron intake is insufficient. The iron need outweighs the intake, or iron absorption is inadequate. These clients are going to have reduced energy. They'll feel cold all of the time. Fatigue and dyspnea may occur with minor physical exertion. Their heart rate is rapid even at rest. They have a decreased hemoglobin, hematocrit, and serum iron levels. We need to find the cause of this issue and treat it. We can give foods that are high in iron. We can also administer oral or parenteral iron. If iron is indicated, this is going to be a supplement. It could be for the iron deficiency anemia prevention or treatment. Things that we need to be aware of is it can cause constipation. It can turn those stools dark green or black to the point where it looks like there might be blood in the stool. It can also stain the teeth. So it's very important to mix oral forms in fluids and or use a straw to help prevent contact with the teeth. We also need to be aware that if we administer this intramuscularly, that we need to use the Z-track method to avoid staining. It is important to administer oral iron with ascorbic acid, like orange juice, because that will help improve absorption. We can also do blood transfusions. It's important as nurses that we encourage an increased iron intake, foods that are going to be higher in iron. So we may need to collaborate with a dietitian. We may need to administer an iron supplement. And again, we need to educate the client on the color of the stools, to take or drink vitamin C to improve absorption. Do not take iron with antacids. And we should always encourage the client to take iron on an empty stomach. And take liquid iron with a straw to avoid that tooth staining. A client requires injection of a parenteral iron for treatment of iron deficiency anemia. The proper route and site for administration of parenteral iron includes which of the following? Intramuscularly using the Z-track method, preferably in the gluteus. Sickle cell anemia is where the hemoglobin is an S or sickle cell or crescent-shaped erythrocyte, and this comes from inadequate oxygen supply to the blood. What red blood cells are there are going to be very fragile and they will rupture easily. Sickle cell anemia is considered a hereditary disorder, and it's most common in African Americans. However, it is also found in Mediterranean Middle Eastern populations. Sickle cell crises, in which the abnormal cells lodge in the blood vessels, cause severe pain. And because of that pain, it's causing that tissue infarction. We're not getting the blood to the tissues, and it can also cause stroke. Triggers for sickle cell crises include dehydration, overexertion, any activity or geographical location where there is an increased oxygen demand, such as high altitudes, and anything that causes vasoconstriction. These clients may have splenomegaly, which can increase infection risk, jaundice, gallstones, chronic leg ulcers from lack of circulation, priapism, tachycardia, dyspnea, cardiomegaly and dysrhythmias, acute chest syndrome, which includes coughing, wheezing, tachypnea, and chest pain. We can diagnose this with the sickle dex test or do hemoglobin electrophoresis. To treat this, we're going to treat it by managing the symptoms, so supportive treatment, and we may need to do some regular blood transfusions, potentially some bone marrow transplantation, and or prophylactic antibiotic therapy if there is an infection involved. With the sickle cell crises, this is one of those instances where clients will be given narcotic analgesia. This is going to be one of the priority issues with sickle cell anemia is managing their severe pain, because what's causing that pain, if you remember, is going to be obstruction of the blood vessels, so the tissues are not getting the oxygen and we have ischemia, aka this equals pain. We're going to administer oxygen, so every breath is going to be the best that it can be. Encourage bed rest, IV fluids, and medications. It's also important to educate these clients on what potential sickle cell crises triggers they are involved in so they can avoid them in the future. A 20-year-old is experiencing a sickle cell crisis. Which of the following interventions is indicated for this client? We need to assess their pain at least every 4 hours. Hemolytic anemia is a chronic premature erythrocyte destruction. So we have an adequate amount of red blood cells, but for some reason they're being destroyed before their usual 120-day lifespan. Causes of hemolytic anemia include cardiopulmonary bypass, poisonings, malaria, and exposure to hazardous chemicals. These clients may have jaundice, that splenomegaly or enlarged spleen, and shock. With microscopic examination, we're going to see a positive Coombs test. So we need to remove the cause. This may require administration of corticosteroids, and it may require blood transfusions. Surgical management, we may have to remove that spleen. And as nurses, we need to get a great health history, provide supportive care, administer medications as ordered, and teach measures of self-care, and of course arrange for follow-up evaluations. With pernicious anemia, we have a lack of intrinsic factor that's necessary for the absorption of vitamin B12, and that intrinsic factor is found in the gastrointestinal system. So it can cause a degenerative change in the nervous system. It can also be secondary to surgical removal of the stomach or small bowel resection. These clients are going to have stomatitis, glossitis, digestive disturbances, diarrhea, dyspnea with minimal exertion, jaundice, irritability, confusion, depression, numbness and tingling in the arms and legs, and ataxia. We diagnose by looking at blood and bone marrow studies. We can also do a Schilling's test or a blood smear. To treat it, we have to administer IM vitamin B12. Vitamin B12 is going to be, once again, administered intramuscularly, and it will be for those deficiencies of vitamin B12 due to malabsorption, gastric bypass surgery, and or pernicious anemia. Make sure that if there's any neurological deficits that we're providing physical therapy. So as nurses, for the glossitis and stomatitis, we need to make sure the client is getting a soft, bland diet. We don't want anything spicy because that is going to really irritate the mouth. Frequent meals and administration of frequent oral care. With the permanent neurological deficit, we need to encourage and assist with ambulation and supervise all of their ambulation. Then we also need to teach the administration of vitamin B12 and make sure these clients are getting plenty of meat, eggs, fish, and milk. A client who has undergone a hemogastrectomy has been diagnosed with pernicious anemia. The client asks the nurse what might have caused her problem. Which of the following is the nurse's best response? The correct answer is you're no longer able to absorb vitamin B12 because of your surgery. Folic acid deficiency anemia, we have immature erythrocytes, insufficient dietary intake of foods that are rich in folic acid. This is often found in clients that have alcoholism, intestinal disorders, poor nutrition, and/or pregnant women. These clients experience severe fatigue, a sore and beefy red tongue, dyspnea, nausea, anorexia, headaches, weakness, and lightheadedness. We can diagnose this with a Schilling's test, and we need to give folic acid supplements. This is going to help improve the folic acid deficiency, help prevent neural tube defects during pregnancy. It's also used to treat tropical sprue. Very important as nurses that we teach the client an appropriate diet, oral hygiene, and promote rest. Now, this is not an anemic situation, but this is what we call polycythemia vera. We have an increase in the circulating erythrocytes and leukocytes. These clients are going to have that really flushed face. It's what we call a ruddy complexion. So their skin can have a reddish purple face and lips. Fatigue, weakness, exertional dyspnea, and splenomegaly may also be found. These clients will require a routine phlebotomy of 1 unit of blood. Unfortunately, this blood has to be discarded. It cannot be used for transfusions. Now we're going to look at leukocytosis, specifically leukemia. Leukemia is a proliferation of leukocytes, usually in an immature form. There are 4 types of leukemia according to the dysfunctional bone marrow stem cell line. We can have acute and chronic lymphocytic leukemia. These come from the bone marrow, and dysfunction will affect the lymphoid stem cells. And then we can have acute and chronic myelogenous leukemia, which are in the myeloid stem cells. Precipitating factors of leukemia include a genetic correlation, exposure to toxic chemicals, radiation, viruses, and some drugs. These clients will experience severe anemia. Now remember, leukocytosis, this is dealing with the white blood cells. So now our clients are going to be at a high risk for infections. Fatigue, easy bruising, fever, enlarged spleen and lymph nodes. Remember, the spleen and lymph nodes are going to be part of our immune system. And if we have an issue with our white blood cells, our spleen and lymph nodes will be enlarged. And there may also be internal or external bleeding. We're going to treat this with anti-neoplastic drugs and/or transfusions, potentially transplantation of bone marrow or stem cells. Multiple myeloma is a malignancy that involves plasma cells. The osteoclasts, remember these are part of your bone cells, break down bone cells and result in increased blood calcium and pathologic fracture. So remember, when the calcium leaves the bone, it goes into the bloodstream. So we now have hypercalcemia, And if we remove the calcium from the blood, then we're going to have those pathologic fractures, or the fractures that occur without fractures that occur without injury. We can also develop osteolytic tumors, which look like punched out or honeycombed appearance in the bones. These clients will experience pain, infection, symptoms of anemia, bruising, nosebleeds, and because we have hypercalcemia, we may have renal calculi, renal failure, again, those pathologic fractures. What we're looking at, the mnemonic, is going to be CRAB. We have elevated calcium levels, renal insufficiency, anemia, and bone lesions. We diagnose this by looking at our skeletal x-rays. We look at bone lesions. We're looking at our serum calcium levels, and they'll probably be elevated. We can also diagnose with a bone marrow aspiration because it will show increased atypical plasma cells. We treat this with steroids, anti-cancer drugs, antibiotics if there is an infection involved, analgesics, blood transfusions. They may require back braces to support the bones and/or body casts. And surgical management would include transplantation of bone marrow or stem cells. As nurses, we have to manage their pain. We need to assess it, assess for signs of infection, fatigue, bleeding, thrombus formation, and urine output. We also need to administer analgesics, encourage ambulation, because remember, ambulation is going to help strengthen the bones. Excuse me, encourage fluid intake. Safety is going to be a high priority. And of course, we need to prevent infection. Agranulocytosis is a decreased production of granulocytes, neutrophils, basophils, and eosinophils, basically all of these white blood cells. It's caused by toxicity from some drugs. These clients experience fatigue, fever, chills, headache, and opportunistic infections. Remember, we have a normal body flora on the body, and if our body is unable to produce the appropriate amount of white blood cells, this flora or bacteria can now take over and create those opportunistic infections. So medically, we need to remove the cause. We need to administer some medications. We may have to do a human granulocyte colony stimulating factor. That would be similar to the erythropoietin, only it's going to stimulate the granulocytes instead of the red blood cells. As nurses, assess how the drugs are doing. Initiate protective isolation, and we may need to restrict visitors, especially those that are showing signs of infection. Excuse me. Pancytopenia is a reduced number of marrow-produced blood cells. So in this instance, we have aplastic anemia. Aplastic anemia is the failure of cells to develop because of inadequate stem cell production. Causes could be autoimmune diseases. It may be exposure to toxic chemicals, radiation, or drug therapy. Basically, it's causing that myelosuppression, so it's killing off the production of blood cells. And remember, our blood cells are produced in bone marrow, red blood cells, white blood cells, and platelets. So these clients will be very ill, and this issue can be fatal in cases of severe bone marrow damage. These clients will have weakness, fatigue, those opportunistic infections. They're going to have unusual bleeding, petechiae, and ecchymosis. They'll have an enlarged spleen and or abdominal pain. We diagnose by looking at the blood cell count and or doing a bone marrow aspiration. It's very important to withdraw the causative agent. Um, One thing I do want to point out is with aplastic anemia, usually we're not going to see these symptoms for a couple of weeks after exposure to whatever agent is causing the issues with the bone marrow. So once we remove the agent, again, it can take at least a couple of weeks before we start seeing an improvement in those blood cell counts. But in the meantime, we may also have to administer blood transfusions of various blood products, antibiotics if there are infections, or corticosteroids. It may also be necessary to do bone marrow transplant or an autologous stem cell transplant. We need to, as nurses, obtain a good history, complete a good physical assessment, identifying all the symptoms the client is experiencing, initiate infection prevention measures and or isolation protocols. Make sure that we are modifying oral hygiene. You know, think of Randy, the mnemonic to help remember with bleeding precautions. We have a decreased number of platelets, and using a regular toothbrush may actually cause bleeding of the gums. So we may have to modify oral hygiene to not use a toothbrush and maybe use swabs instead, for example. And we also need to monitor any blood transfusions that are being administered. Then we have some coagulopathy disorders. This is where a component to control bleeding is missing, or we have inadequate uh, coagulation components. This would include thrombocytopenia and hemophilia. With thrombocytopenia, remember thrombocytes are another name for platelets. So we have a decreased manufacture of platelets by the bone marrow, or platelet destruction by the spleen is increased. Causes could include leukemia, a malignant blood disease, and or severe infections. There's a couple of different types of thrombocytopenia. We have idiopathic thrombocytopenic purpura, and that would be thrombocytopenia that really doesn't have a cause that we can identify. And heparin-induced thrombocytopenia, which is a drug-induced thrombocytopenia. These clients are going to have purpura. Remember, that's going to be a purple discoloration of the skin, bleeding, and potentially internal hemorrhage. It's very important that we eliminate the cause. It may require the administration of corticosteroids and transfusions. Surgically, it may require a splenectomy to remove the spleen. It's very important that we initiate bleeding precautions to manage and minimize bleeding, and be aware of any adverse drug reactions. If we administer corticosteroids, make sure that when it's discontinued, that we taper the dosage and the frequency. Hemophilia is another coagulopathy that is due to the absence or reduction of a clotting factor, such as factor 13, 9, factor 13, 9, or 11. This is an inherited issue and it's inherited from the mother to the son. So it's usually males that will develop this disease. Women will rarely develop hemophilia. These clients will have a persistent oozing, severe bleeding, and maybe even bleeding in the joints if there has been an injury to the joint. We look at their coagulant factor assay to determine if hemophilia is present. We manage it by giving blood transfusions or thrombin fibrin application. We can also transfuse fresh frozen plasma. And definitely for bleeding, we need to apply direct pressure. But understand it may take a while to slow down or stop bleeding with these clients. Nurses need to obtain a great health history, complete a good physical assessment, obtain vital signs, prevent trauma, minimize bleeding. So again, we institute those bleeding precautions, reduce pain or discomfort. It is important to teach these clients how to conserve energy and how to prevent further episodes of bleeding. Disseminated intravascular coagulation, or DIC, occurs when there's an overstimulation of the normal coagulation cascade that results in simultaneous thrombosis and hemorrhage. This is what we call a hypercoagulable state. This issue is always secondary to another pathologic process, such as an overwhelming sepsis, shock, major trauma, crush injuries, burns, cancer, acute tumor lysis syndrome, or obstetrical complications such as abruptio placentae and fetal demise. So what's happening is coagulation occurs at so many sites that eventually all the available platelets and clotting factors are now depleted, and now we have uncontrolled hemorrhage. So blood tests that are going to help diagnose DIC include a prothrombin time, a partial thromboplastin time, fibrinogen and thrombin time, a fibrin split product level, and D-dimers. It's difficult to treat these clients, and if you look at the picture on your slide, you can see that this client is obviously very ill, has a lot of purpura on his face. We can administer blood component replacement therapy, such as administration of platelets, but again, we're replacing those platelets, we're replacing lost blood, but we can need to interrupt that DIC cycle. So we can administer heparin and then allow the body to replenish platelets and clotting factors. But both of these treatments are controversial. You know, they are having bleeding sites, so we need those clotting factors. But now we give heparin, which is going to help prevent clotting. So very, very tricky to treat. So antiplatelet medications might include aspirin or clopidogrel. And basically what it's going to do is help prevent thrombosis in this case. It also reduces the risk of strokes. It is going to be contraindicated if we have thrombocytopenia or active bleeding. But once again, with DIC, we're trying to prevent the thrombosis, but at the same time, we have bleeding going on. So a little tricky. These The next type of medication would be the anticoagulants, once again to help prevent clot formation. It is important to realize that bleeding is the main complication. So it, in this situation, would be a little tricky to administer. If we do have an elevated level of warfarin, we can administer the antidote vitamin K. If our heparin levels that are exhibited by our blood test, the APTT, we can administer protamine sulfate. So these drugs include, on an oral basis, warfarin is going to be the most common. We can also administer anticoagulants subcutaneously or IV. The only IV one that we would administer would be heparin. But we also have those low molecular weight heparins, such as enoxaparin. This would be subcutaneous only. Do understand that these syringes come pre-filled and they have an air bubble in them with enoxaparin. Do not expel the air bubble prior to administration. Then we have thrombolytics, and thrombolytics are not going to prevent clot formation, but they break down clots that have already formed. And those clots can be a couple of weeks old. So any clots that have formed, it will basically dissolve them. So be aware that an adverse effect is we can have hemorrhage. The drug that we're talking about here would be alteplase, also known as TPA. So again, looking at this picture, you can see that this condition is extremely serious, and it is not uncommon for the client outcome to be fatal. If I'm not mistaken, and I might be, fatality occurs in about 50% of these cases.